about the health infrastructure in India as well as in West Bengal? Do you have any idea? Definitely you have the idea. Can you remember? If nobody told you, I told you. What are the prevailing infrastructures in health system or healthcare delivery system? Mone ache? Anybody can tell me? Ekbari mone nei na? Okay. Now, perhaps few of you at least, or at least 50% of you are from rural areas. In West Bengal, in the periphery level, in the grassroots level, which infrastructure exists for healthcare delivery systems? Who will provide healthcare services in the lower level, in government sectors? Which organization is there in the village level? বলো, মুখ খোলো, ভুল হতে পারে, হোয়াট ইজ দ্য হার্ম? বসে বসে বলো, কোনো প্রবলেম নেই। পেরিফেরিতে কি আছে দেখো, চোখে তো দেখো। গ্রামের লোকে কোথায় যায়? হোয়ার ডু দে গো ফর সিকিং হেলথ কেয়ার? প্রাইমারি হেলথ সেন্টার। ও এখানে বলেছে, গুড বলেছে, প্রাইমারি হেলথ সেন্টার। তার নিচে কি আছে? beneath this primary health centers, there is an organization which cater the need of 5,000 populations. There is a sub-center. In the sub-centers in West Bengal, there are two ANM. Okay, two ANMs are there. Okay, one is regular and one is contractual. They used to provide healthcare delivery services to the villagers. Sub-center, there is no doctor. Then, to serve the 30,000 populations, there is a primary health centers. Okay. Then, in the block level, there is a block primary health center, or sometimes we call it rural hospitals, or sometimes we call it community health center. Can you remember? Sub-center which caters how many population? 5,000 in plain area, and in hilly area, tribal area, 3,000 populations. Fine. Then primary health center, there is a doctor. Number of doctors are there. The primary health centers, for every 30,000 populations in plain area, there is a primary health center. In tribal area or hill area or in difficult area, for 20,000 populations, there is a primary health center, and in block level, for catering the needs, rather the healthcare needs of the populations, 1 lakh populations, one BPHC or CHC or rural hospitals. But within the existing healthcare delivery systems, all the health problems or all the health needs of the entire community cannot be catered. For that reasons, since 1951, just after the independence, when the planning commissions was started in 1950, then 1951, first 5-year plan started. From that time, the healthcare pioneers thought that within the existing healthcare delivery system, which was started again in the year 1946, on the recommendation of what I told you, all these things on the recommendation of Sir Joseph Board Committee. 1946, that Board Committee under the chairmanship of Sir Joseph Board submitted the reports. On the basis of that, healthcare delivery structure, that means there is no concept of BPSC, started with PSC, primary health centers. But since then it was thought that within the existing healthcare delivery system, it is not possible. What is very difficult? To meet the needs of the entire community. For that reason, side by side, different national health programs were started. Different national health programs. In Bengali we call it Jatiyo Sastho Kormosuchi start হয়েছিল since 1951. Okay. Now, few programs are called or now called health promotive programs. Few programs we call it preventive and control program. So, there are number of national programs. Perhaps it has been discussed. National programs, Jatiyo Sastho Kormosuchi. Can anybody name at least one or two national program? বলো বলো polio vaccination national program নয়, that is under RCH, definitely that is under RCH. Previously it was national immunization program. In the year 1985 it was started, then it merged with RCH. Now we call it RMNCH plus A. Okay. Reproductive, M maternal, N for neonatal, C for child plus adolescent health. RMNCH plus A. Like this. ICDS program simply is a social welfare program definitely. But everybody knows about the ICDS programs. ICDS programs. RNTCP, Revised National Tuberculosis Control Program, National AIDS Control Program, National Vector-Borne Disease Control Program. So, there are number of national programs. Each national programs has its own objective, goal, strategy, then implementation. So, when implementation and evaluations, not only it is applicable in case of national programs, in all programs. Suppose we are conducting this program, key program, MBBS program. Okay, we have to plan it. Now we are going to implement. While implementing it, again, evaluation system is there, is it? So, today I will discuss about the steps of evaluating health promotion and education programs. I told you, আমি বললাম কি প্রোগ্রামগুলো দু রকমের হয়. There are two types of programs. One is health promotive program. Another is prevention and control program. Promotive means the people are not suffering from any health problems, any disease. There is health problems. Now, best examples is breastfeeding promotion programs. We are trying to promote breastfeeding. There is promotive programs, not prevention, not control. Okay. So, now the steps of evaluating all the national programs, including health promotive programs, are the same. Today, just in brief, I will discuss with you, or rather I will exchange my views and opinions with you about the steps of evaluating different national health promotion and education program. Okay. Now, evaluation. What does it mean? Evaluation means in Bengali call it Mulayan. Evaluate. Okay. Whether the preset objective had been achieved or not. Say for example, at the end of the MBBS examinations, evaluation is there, how many students have passed, what percentage of students have got 80%, 90%, 60%, 70%. So, these are the evaluations. So, there are some steps. Likewise, what is program evaluation? Program evaluation is the systematic gathering. Gathering means collecting. Systematically, we have to collect data about the program, what are the deciding factors that affect the impact of the program, or rather we can say what are the impact of the programs. On the basis of that, we try to collect data. Gathering means, say for example, examples is breastfeeding promoting program. our target was at the end of 2022, we promote breastfeeding among 90% of the lactating mothers. So we have to collect data from them. So gathering, data collecting, once we collect data, then we have to analyze it. So evaluation program is the systematic gathering, analysis. Once we analyze it, then try to interpret the meaning, interpreting and reporting of data about a program to assist in decision making. If there is any fault, if there is any lacunae, automatically we have to change the program. We have to change not only the program, we have to change the strategy of the program. We have to change the activities that has been undertaken to implement the program. Rather, we may have to change the plan, the program. The way we plan, that may be faulty. The way we are going to implement the program, that may be faulty. There may be a shortage of staff. There may be apathy from the respondents to accept the programs. So automatically it will help to assist in decision making. Now, question comes about the data gathering. Usually there are two types of data. Now we collect for any study right now. Previously we thought about quantitative data. Now we are thinking about both quantitative and qualitative, that is mixed methods. Okay. This type of efforts produce the information needed to design or improve the effectiveness of health promotion efforts. Is it clear what is program evaluation? মানেটা হচ্ছে কি একটা নির্দিষ্ট পদ্ধতিতে আমরা তথ্য কালেক্ট করব, তাকে অ্যানালিসিস করব, তাকে ইন্টিগ্রেট করব, দিয়ে তারপর তাকে ডিসিমিনেট করব কি করার জন্য, টু ইমপ্রুভ দি প্রোগ্রাম, the effectiveness of the program, that is will be helpful in decision making. By collecting two types of data usually, one is quantitative and there is qualitative. Quantitative মানে কি? Can anybody tell what is the meaning of quantitative data? Number. The data that can be expressed in terms of numbers. Or quality, bhalo ki kharap, good or bad, like this quality. Okay. Next. Now, this is your topics for today's discussion. There are 10 steps. Steps means series of evaluating a health promotion and education program. Okay. So, you can expect these type of questions in the examinations or during the postgraduate details. You have to know about this each and every step in details. Today just I will discuss in brief the step. What is the step? First step is clarify the program. Suppose I as a person or I as a team member, okay, member of the evaluation team, going to evaluate the effectiveness of any program, whether the preset objective has been achieved or not. The step is clarify the program. What is the program exactly? That we have to clarify. Otherwise, আমরা যদি কিছুই না জানি program সম্বন্ধে, then how we can evaluate the effectiveness of the program? First one is clarify the program. Second one is engage stakeholders. Stakeholder means the persons or group or organizations which are directly or indirectly affected or beneficial through this program. That means all the beneficiaries. In case of ICDS, for example, ICDS perhaps you know, that's why I am trying to tell you. ICDS ধরো একটা program, it's a program. The beneficiaries কারা কারা আছে? ICDS program who are the beneficiaries? ICDS program beneficiary কারা? বলো, তোমরা দুজনই বলবে, আর তো কেউ বলছে না। বাচ্চারা, কোন বাচ্চারা? age less than 6 years. Good. Less than 6 years, up to 6 years, 0 to 6 years are what the beneficiaries apart from the children. Though the name indicated child development services scheme, still apart from the children there are different beneficiaries. Ekta hocche one group is children and these mothers and these adolescents. Okay, so they are the stakeholders. So we have to engage them. যদি তাদেরকে এনগেজ না করি তার আমরা ডেটা কালেক্ট কাদের থেকে করব? From them we will collect data. So if they are not coming forward, if they do not cooperate with us, then how we can collect data? If we cannot collect data, we cannot evaluate the impact of this program. And third one is assess resource and evaluability. What are the resources that are available for collecting information, for analyze the data or analyze the information, for interpreting the information, for disseminating the information to the authority. So third step is assess resources and evaluability, and fourth step is determine your evaluation questions. In any research study there are some questions. So in any study you have to answer, you have to get the answers of these questions. So you have to prepare or determine the evaluative questions. So on the basis of that you will ask, I will tell you what are the questions. Next step is determine appropriate methods of measurements and procedures. What are the procedures? What methods we will follow to collect data? Next, this most important is on the basis of all these, we have to determine your evaluation plan. How to evaluate a program? How to evaluate a program? Maybe process evaluations, maybe impact evaluation, but evaluation, both. Develop evaluation plan, that is most important. Okay? So these first 6 steps are called the planning part of evaluating any health promotion and education program. The next 2 steps, that is collection of data and analysis and interpretation of data. Next step, collection of data and process and analysis of data. These 2 steps are called implementation stage. We are trying to implement for assessing the impact of any health promotion or health education program. And last 2 steps, that is utilization steps, interpret and disseminate the results to the authority, to the community people, to the what I should say bureaucrats, to the autocrats, all. And last step is apply evaluation findings. So the steps we can divide into 3 parts. One is planning, one is implementations, and third one is utilizations. First 6 steps are called planning, second 2 steps are implementation, and last 2 are utilization. These 10 steps are very important. Okay, one by one. In brief, I will try to discuss with you today. The meaning is that clarify program maneta ki. What is the meaning of the clarifying program? This step is about forming a strong foundations for program evaluation. Until unless people, I mean the stakeholders, the core group and the involvement group are not aware, are not clear about the program goal, about the program objectives, about the beneficiaries. So it is not possible to evaluate. So it is important to assess whether the program is, next one is it is important to assess whether the program is ready for evaluation. Say for example, if a program is going on, so until unless it is finished or until unless it is reached to a certain step on the basis of which we can assess the impact, ভালো কি খারাপ, কতটা হয়েছে, কতটা ফুলফিল হয়েছে অবজেক্টিভ, একটা নির্দিষ্ট স্টেজ পর্যন্ত না যাওয়া পর্যন্ত it is not possible to assess. For that reason we have to think, is the program is now ready to evaluate? যেমন তোমাদের ধরো কোর্স ফিনিশ হয়েছে কিনা, তোমাদের ডেট ঠিক আছে কিনা, 1 বছর হয়েছে কিনা, তবে তো ইভালুয়েট করবো আমরা। হঠাৎ আমরা একটা ইভালুয়েট করলাম, মাঝখানে মনিটর করা হয়, internal assessment. That can be done. That is called monitoring, not evaluation. Okay. It means gathering information about the program and sharing it with the stakeholders. Why this step is important? To plan a program evaluation, you need to clarify about the program and what it was intended to achieve or intended to accomplish. First, we should know about the objective. কি করতে চাইছি আমরা এই প্রোগ্রামের মাধ্যমে? What we want to do. So we have to be clear about this. But yes, how do I do? কিভাবে করব? Number one, program goals are defined. One program has been started. So I told you, when national program or any health promotion program starts, it has its goal, it has its objectives, it has its strategy, it has the activities, all these things are there. So first we should know, before evaluating, our uddesho goal ki chilo, what was the goal of that program, and is the goal is realistic. Next, information needs are well defined. Third one, intended users are willing and able to use evaluation information. যাদের কাছে আমরা যাব evaluate করার জন্য, to ask some questions or rather I should say relevant questions for evaluating the impact or evaluating the successfulness of the programs. If they are willing, যদি তারা এগিয়ে আসে, তারা যদি cooperate করে, then only it is possible to collect information from them, otherwise not. Then evaluation data are obtainable, যে data আমরা চাইছি সেই data কি পাবো? If we hope to get it, then we can think yes, the program is ready for evaluations, otherwise not. So first we call it community preparation. Before we start any program, we have to prepare the community. Okay. Then only we start data collection. Okay. কিভাবে করব? How do we do this step one? Program goals. We know the program goals. We have to write down the program goals. We have to know about the program goals. Population of interest means stakeholders. What are the stakeholders? And third one is very important, outcome objectives. What is outcome objectives? And outcome objectives spells out how much of what should happen, to whom, by when. How much of what should happen, to whom, by when. Can I give one example? How much of what? Say for example, 100%. I am telling about the percentage, not in numbers. You can convert in numbers also. Percentage. How much of what? Suppose there are 100% mothers. Okay. Breastfeeding program. I am telling about the breastfeeding program, the important program. 100% mothers of what? Tamane out of 100%, how many percentage I expect? Out of 100% mothers, at least 80 or 90 or 70. That we have to think. Happen to whom? That means mothers. মায়েদের হচ্ছে চেঞ্জ হচ্ছে অ্যাটিটিউডের, প্র্যাকটিসের চেঞ্জ হচ্ছে, প্রমোশন অফ হেলথ ব্রেস্টফিডিং বাই হোয়েন, কতদিনের মধ্যে। দ্যাট ইজ কল্ড আউটকাম অবজেক্টিভ। দ্যাট ইজ ভেরি ইম্পর্টেন্ট। Then we have to think about what is the strategy, what were the activities undertaken on this program, and what resources are assigned, কি কি resource utilize করা হয়েছিল for implementing the program. And next one is output, outcome নয়, output. Process objective. A process objective tells you how much of what you will do or produce. আমাদের আইডিয়ালি কি ছিল, আউট অফ 100% আমি বললাম আইদার 90 or 80, বাট তুমি কতটা করছো? তুমি বলছো আমি I means the program coordinator or the whole program within 1 year, out of 100% mothers, at least the attitude and practice of 60% mothers will be changed towards the promotion of breastfeeding or breastfeeding their child up to 2 years and up to 6 months exclusive breastfeeding. Okay, by whom? When? Process objective sometimes called output. So there are two things very important. One is outcome objectives and there is process objectives or outputs. That is very important. The first is over. Second stage, okay, this is in black and white. The first stage in black and white. About the program, আমাদেরকে জানতে হবে what is the program, what was its goals, objective, strategy, who are the beneficiaries, when it was started, what were the outcome objectives, what were the outputs, all these things we have to know আমাদের কি উদ্দেশ্য ছিল. Then we proceed. How to proceed? We have to engage. Suppose you are the beneficiaries. So we have to engage the beneficiaries or stakeholders. Because if we cannot able to engage yourselves, nothing will happen. I am discussing the class, nobody has come. So what is the utility of taking the class? That means you are not ready to receive it. Likewise, you have to engage the stakeholders. Who are the stakeholders? আমি আগেই বলেছি, just repetition. Stakeholders are the people, groups or organizations that the program or evaluation could affect. Indirectly, directly, যারা উপকৃত হবে, যাদের উপর ইনফ্লুয়েন্স পড়বে আমাদের প্রোগ্রামের, তারাই হচ্ছে stakeholders. Now, can you tell me, so in the MBBS program, yes, who are the stakeholders? বলো. Now, MBBS course is going on, running. Who are the stakeholders? Program এ বলো. তোমরা means the students, bas, alone. Who are the stakeholders? Students are একটা গ্রুপ তো নয়, they are different groups. বলো, তোমরা বলো. Who are the stakeholders in MBBS program? Just giving an example. Somebody told the students group, they are the stakeholders. Apart from the students, কারা? Not government. Government the last আসবে definitely. Stakeholders মধ্যে who is the teachers? The teachers are the stakeholders. Are stakeholders কারা? ওই যে বসে আছে, the supporting staff. All are the stakeholders. এই যে MBBS প্রোগ্রামের উদ্দেশ্য everybody should know. We should like to spell out this program activity among all of them, all of the stakeholders. In this step, while evaluating any program, what we have to do? We have to engage stakeholders. But you see, among yours, representatives are there. Is it? Few representatives are there. Is it or not? Representative. Okay. These representatives will involve or engage right from the beginning while planning the program, while implementing the program. I mean, planning the evaluation, implementing the evaluations, utilizing the evaluation program. Okay. This is the core group. Core stakeholders will involve every time in every spheres, always, and some stakeholders are there one time or two time. Whenever needed, we engage. Some stakeholders will participate throughout the planning, implementation and use of the evaluations, and you may consult others just at key points. Whenever we require, we engage them. Okay. So this is the second step. Now, why it is important? Why is engaging stakeholders important? Many health promotion efforts are complex. So stakeholders take on particular importance, providing perspectives that may not be clear in a single vantage point. একবার করলে হবে না, কন্টিনিউয়াসলি তাদেরকে এনগেজ করে রাখতে হবে. So it is vital to solicit their opinions. তাদের opinions আমাদেরকে seek করতে হবে. We have to seek their opinions. We have to think about their interests, and we have to think about their concerns and priorities early in the evaluation process. Next one, how do you do the step 2? কিভাবে করব? What will you do? Identify the potential stakeholders. Who are the potential stakeholders? To consult about the evaluations. Identify their interests. তারা কারা? Who are they? What about their interests and roles in evaluation process? Engage stakeholders in reviewing our program. Say for example, we are planning the evaluation of the program, but they are not totally satisfied. Then we have to consult them. With their consultations, we can review the program evaluations and engage stakeholders in brainstorming. Say for example, আমাদের দ্বারা হচ্ছে না, what we are thinking, they are not satisfied. We are engaging them, then we are organizing a program that is called brainstorming. That means they are thinking, okay, what are the right way to evaluate the effectiveness of any programs. So that is called engage stakeholders in brainstorming key areas of your program evaluations, including its principles, uses and questions. Main thing is, whenever we plan an evaluation, then you have to frame some questions. So about the questions also, they can share their views. Now, this is the stakeholders. This is called stakeholders wheel. Core stakeholders. That means core stakeholder means the person concerned, the group of persons. সেই গ্রুপ যারা কি করছে evaluate করতে যাচ্ছে, একা তো সম্ভব নয়, it is not possible. So core team will be there. Say for example, WHO are interested to evaluate so many programs, so many staffs are there, right from the coordinator, evaluation officer, program director. So they are the core groups, and then involve other groups, the other circles, just outer circles. Involve, what are the persons who can be involved? Say for example, data collector, just you will train them, they will collect data. Okay. Then supportive, peripheral group, they can support them. So first is core group, then involved group, then supportive group, then last is community people, peripheral group. In the community, leaders, only the leaders, informal leaders, formal leaders, and last one here is community people whole. And again you have to engage, maybe health education program, maybe health program, but you have to engage both health sectors and non-health sectors, because health cannot be achieved alone. If you want to achieve health, we have to take the help of all the sectors, like apart from health, education, industry, agriculture, communication, transport, program, water supply. So all sectors we have to involve. Okay, health sectors, non-health sectors, and again government as well as non-government sectors. So this is called stakeholders wheel. So you have to engage all the stakeholders, always or sometimes, and seek their opinion. Then only your evaluation program will be successful. Second step is over. Okay, now we are coming to the third step. What is the third step? Assess the resources and evaluability. How we can assess the program? With whom we can assess the program? What are the resources available in our hand? With their assistance, we can evaluate the program. So now this is the time to clarify the resources available for your evaluations. At this stage, you means a group of people, your team and your stakeholders should have a general sense of evaluation. What is evaluation? Why we will evaluate? What are the program objectives? Everything in detail they should know. And what are the questions? Which questions will you ask to whom, when, how, what procedures, that they should know. Why this step 3 is important? Resource is important because evaluation can be time consuming and expensive. একদিনে হবে না. It is not possible to complete it one day. Maybe years together, 2 years, 3 years, 4 years is required, and it is too much expensive. And many times it happens, small programs, funding is small. So due to the paucity of fund, program evaluations cannot be completed. Some people cannot complete their evaluations due to constraints. So you can avoid these things by assessing the available resources. So if we can assess the resources that are available within our hand, then within a time frame we can be able to complete our evaluations. কিভাবে করব? How do you do the steps? There are two main tasks. Number one, identify the resources available in our hand, and second one, determine whether the evaluation is appropriate for your program. Now again question comes, now whether the time has come to evaluate the program. Implementation এতটা হয়েছে, এতটা জায়গাতে 50% হয়েছে or 30% হয়েছে. So we have to know during this stage, is it possible to evaluate the impact of this program? Then only you can start. This is also resources. Identify the resources. This is not that much important to know for you in this stage, but yes, definitely what are the resources? Staffs and salary of the staffs. Number one is consultants, and third one is supplies and equipment. Next one is communications, time. All are the resources that you have to think of. Okay. Determine whether evaluation is appropriate for your program. Dorkar nei. Chalo next. This is important. Step 4. Determine your evaluative questions. Now, I can give examples to you. So, in your group 3, your group, yesterday you have framed some questions. So, on the basis of these questions, you will start in program. Now, just reverse. Program is over. We are going to evaluate the impact of these programs. So, we have to frame the questions. So, framing the evaluation question is very important because you have to get the answers of these questions from the respondents in time. So, at this stage, you and your stakeholders should have a clear understanding of the program. Why this step 4 is important? Because you see, number of questions you can frame. Okay, first you will frame so many questions. Then you have to narrowing down, means short list. You have to shortlist these questions, few questions, because you see, if you want to raise so many questions to the stakeholders or the beneficiaries, what will happen? They will lose their interest. So, you cannot get the feedback from the beneficiaries. So, your program evaluation cannot be completed. So, for the reasons, few questions, few very pertinent, important, precise questions you have to frame. That can help you to decide the best uses of your resources. Creating a short list of questions can be useful too when communicating the evaluation to others. Ki evaluate korcho tumi? देखी तुम्हार questions, so few questions only. इतना बड़ा question नहीं है. 4, 5, 6, 7, 8, 9, 10. Because you see, usually what we do when we frame questions, thinking about the time. Because who are the most important stakeholders? The beneficiaries. যাদের কাছে আমরা to whom we will go to ask questions. So usually schedule we frame maximum 20 minutes, maximum 25 minutes. Within 20 to 25 minutes or 15 minutes, the answers will be completed by the respondent. Then only they will be agreed to cooperate with you for evaluating your any program. কিভাবে করব আমরা? You will need to complete main 2 tasks. One is select and refine your evaluation questions. Again, define your evaluative questions. Determine appropriate evaluation approaches. কিভাবে করব? How you will approach? কিভাবে করব? Need assessment, that is very important, but you see usually it happens in the implementation stage of any program. Previously at the first step, we assess the needs of the people, then only we frame the program. Until unless need is there, we do not frame any national programs. So assess the need, then this is process evaluation. Process evaluation means the way we are moving, the procedure we are following to evaluate any program. Is it planned? Plan wise হচ্ছে কিনা? আমরা যে প্ল্যান করেছিলাম, previously we have planned how to implement the program. So সেই প্ল্যান অনুযায়ী implementation হয়েছে কিনা? So that is called process evaluation. Process evaluation help you to understand if the intervention is being implemented as planned and reaching intended participants. Okay, so that is all about today's. Only 4 steps I have completed. Okay, when opportunity come, other 6 steps I will complete. Okay, so can you tell me now what the 4 steps only? Only tell me the 4 steps or 10 steps. Who can tell the 10 steps? So for the first step, আমি ছাড়বো না কিন্তু না বলতে পারলে আমি নড়বো না. What is the first step of evaluation process? আর 4th step কি ছিল যেটা এখনো রয়েছে? Determine evaluative question. তাহলে 4টে জিনিস I discussed. One is, first step was clarify the program. That means everybody must know key program cholche. What are the programs that are prevailing? That a program is going on. Sei sambandhe everybody must know what is the program, what is the objective, what is its goals, how it is being implemented. That means what are the activities, what are the strategies, কিভাবে চলছে. Okay, that is the program. So team must know about the program, and next engage the stakeholders. Stakeholders means not only the target population. Target is the student only, but stakeholders means all people who are engaged directly or indirectly. Engage the stakeholders. And third, আমি যে class নেব, what are the resources available that will be required for me to discuss with you in the class? That means assessment of resources or availability of resources. And last, key question করব, how to evaluate, what are the questions that will frame, minimize the question, solve the questions, okay, so that we can proceed for evaluation. Okay, any questions? Ready to answer? This is very important, I am telling you, in future. Steps of evaluating and health education program or national health programs.
Journalism is spiral, and the most importantly, their cytoplasmic membrane. Outside the cytoplasmic membrane is cell wall, and another coverings are there in case of these spirochetes, and within this cell wall and the outer membrane of spirochetes lies flagella. So these are the special type of flagella which are present inside this cell structure. Obviously, this is called endoflagella. So two types of flagella exist. One we know is exoflagella, projected outside the body of the bacteria, a very thin thread-like structure, the organ of locomotion. Similarly, a special type of flagella is present, is responsible for a special type of movement of these group of bacteria. Ordinarily, there are different types of flagella and different types of motility we know. Stately motile, undulating motile, jerky motility, and there are different types of motility there. But here, due to endoflagella, the motility is like extension and flexion, corkscrew type of movement, and translatory movement, that is to and fro. So three types of specialized motility spirochetes exerts. A catch question on examination table: what is endoflagella and what type of motilities they exert? Answer is, sir, this is endoflagella. It lies between the cell wall and the outer coverings of spirochetes, and it is responsible for three types of motility, what I have mentioned. So this is the special character of spirochetes. Spirochetes within this group is Treponema pallidum, the causative agent of syphilis. Sexual exposure is the only reason of syphilis contract. Other than that, there is a possibility, although remote, that is during transfusional propagation. Following transfusion, blood transfusion, syphilis can occur. That's why we perform VDRL test before giving blood donation or blood sampling, etc. So VDRL test is a very important test of screening syphilis in blood. Now, as syphilis, it has three important stages. After contracting the disease due to sexual exposure, even oral sex is also responsible for contracting the disease. So, mucocutaneous connection following any shots of laceration may result in syphilis. Human, they are the usual carrier, and after the primary exposure, the first exposure, the incubation period is 10 to 90 days. Within this period, usually 2 to 3 weeks after the exposure, the primary lesion on the sexual organ develops. It develops as a very small papule. What is papule? A small blister-like lesion on the sexual organ, less than 1 millimeter in size, and it is elevated on the body surface. If it is flat, it is macular. If it is slightly elevated, then it is papule. So a papular lesion develops. Very soon, multiple papule develops and they ulcerate. Ulcerate to form a lesion on sexual organ, which is known as heart chancre. It is indurated. That means if you palpate it thick, very thick to palpate, and exudate, a glistening exudate covers the entire part. So it is painless and very hard chancre which appears first. This is the first feature of primary syphilis. In compared to this soft, painless lesion, another lesion from a sexually transmitted disease is known as Haemophilus ducli ulcer can occur, which is painful. So differential diagnosis lies between two diseases. One is STD by Treponema pallidum, and the other one is by hard chancre, and soft chancre is by Haemophilus ducli, that is chancroid. So we have two differential diagnoses. One is painless, syphilitic ulcer is painless, and Haemophilus ducli is painful. Later on, limb adenopathy, limb nodes are palpable, and within 4 to 6 weeks it heals completely without any treatment also. Then within 6 to 12 weeks, secondary syphilitic rashes appear on palm, on a hand, any other organ of the body, and also the lesion is subsequently seen as condylomata. Condylomata, that means a warty growth, a wart-like growth with a pedicle, a wart-like growth on the sexual organ. Very humiliating disease. A warty growth, cauliflower growth on the sexual part. The secondary syphilis. Subsequently, this is also called the mucocutaneous junction syphilis, and as well as the condylomata appears. The disease automatically heals up and it enters into the latent phase. Within this latent phase, often the tests are negative. Nowadays, these type of sexually transmitted diseases are complicated with HIV infections. When there is HIV, simultaneous infection with the syphilis, the pictures are more difficult to diagnose because the serological tests are intermittently positive. I have mentioned the name of VDRL test as a screening test or marker of syphilis, the venereal disease research laboratory test. This laboratory is situated in New York, America. The recent name has changed from VDRL to TEIA. Anyway, this VDRL lab, they first started this VDRL antigen test. Now this test is intermittently positive if syphilis is complicated with another STD, that is HIV. You know that in HIV infection, the entire immunological system is lost. No immune challenge from the body. So no immunological test is positive now. This is a bit difficult conditions for the clinician to diagnose nowadays. Anyway, the final stage is the tertiary stage of syphilis, where the neurological involvement, the cardiological involvement occurs, which is known as neurosyphilis and cardiovascular syphilis. Subsequently, the patient's condition is worst because this is known as tabes dorsalis, general paralysis of insane, a vague look, semi-consciousness gradually appears. So this is the tertiary stage. This stage is usually not seen now after the advent of penicillin. Penicillin is the drug of choice. How to diagnose this syphilis? There are several tests. If you see the different type of antigen, the extremely outer layer is responsible for genus-specific antigen. This genus-specific antigen is present all these trispirochetes like Borrelia, Leptospira and Treponema. This is genus-specific. So not at all specific for Treponema pallidum. It is genus-specific. The first antigen is also known as Treponema reters protein, reters protein, R-E-I-T-E-R-S, reters protein. This reters protein can be cultivable, although Treponema pallidum is not cultivable. So here the Koch's postulates these are violated. Koch's postulates violated because in Koch's postulate each and every bacteria is cultivable, but here you cannot cultivable. You cannot cultivate Treponema pallidum. It is uncultivable or non-cultivable. So Treponema pallidum, especially retard strain, or Treponema fajdenis, which is genus specific, can be cultivable, but Treponema pallidum, the specific layer of the spirochetes, is not cultivable. So certain species are there which are not producing syphilis, are called non-syphilitic Treponema. They can be cultivable, but syphilitic Treponema cannot be cultivable. Only we can pass this type of strain, which is known as Nicol strain, into rabbit testes. And even from 1942, when the last case of tabes dorsalis or neurosyphilis occurred, from that patient we have collected the material, and now it is serially propagated in rabbit testes, and from where we can get the Nicol strain. This Nicol strain is specific specific and specific for Treponema pallidum. For identification or confirmation, this particular Nicol strain is used. So, another strain is retard strain, which is non-specific, which is not used for syphilis, not used for Treponema pallidum, but Nicol strain is used. Another non-specific antigen is there, which is known as cardiolipin antigen. This cardiolipin antigen may be present in Treponema, may be present in the human tissue, may be present other than human cells, in ox heart also. So, if you collect antigen from ox heart, this is also a cardiolipin in nature and can produce immune response. The antibody produced by this cardiolipin is known as reagenic antigen. Reagin is a misnomer, because reagin, you know, from IgE antibody, that is one reagin. So, this antibody which is produced against the non-specific antigen present in ox heart, which is used as a non-specific test of syphilis, which is not sure that whether this antigen is derived from Treponema pallidum, which is not sure that it is derived from host cell, even it is not sure that it is derived from the ox heart, we are unknown, then it is a non-specific test. Although we are collecting the material from ox heart, which is easy to collect, we use that ox heart antigen as cardiolipin material for VDRL test. So, the full name of VDRL is Venereal Disease Research Laboratory. This is a non-specific test as cardiolipin antigen is used, because this cardiolipin antigen is shared by the Treponema pallidum, the host cell tissue, as well as ox heart. This cardiolipin antigen once again is standardized by adding lecithin and cholesterol to evoke a similar type of reactions among the other tests of non-specific nature. The other tests for non-specific tests known as VDRL test as well as RPR test. RPR stands for Rapid Plasma Reagent Test. Rapid Plasma Reagent Test, RPR. Another test is there known as orthotoluidine test and trust antigen. These are the 4 tests used with cardiolipin antigen, which is non-specific in nature, collected from ox heart or beef extract. So, this is a non-specific test. If it is positive, then we can conclude that may be a case of syphilis. Not sure. We have to done a confirmatory test again with a confirmatory antigen, which is known as Nicol's protein, Nicol's antigen, and the test is known as FTA-ABS, fluorescent tagged antibody absorbed. So, FTA-ABS, TPI, TPHA, they are the confirmatory test where Nicol's antigen is used, because that antigen is specific and specific. Now, cardiolipin antigen, what is the advantage? Why till date we use this cardiolipin antigen? The point is that the FTA-ABS test or the shearest test of syphilis, once positive, it remains positive for life. So, there is no prognostic value. When we are treating our patient, how can we understand that a patient is getting cured or patient is free from syphilis? From FTA-ABS, once positive, it remains positive forever. But VDRL test, the screening test, definitely it has a prognostic importance, we can titer it and we can express the result as positive 1:8, positive 1:16 and different type of titration, and with the treatment the titration value gradually goes down. So, this is the importance of VDRL test. Till date we are performing this VDRL test. Why? The answer is here. These particular group of tests used cardiolipin antigen are called STS, or standard test of syphilis. There is a catch question in oral examination. Why this group of antigens are called standard group of test or standard test of syphilis? Because these antigen, this cardiolipin extracted from ox heart or beef heart, these are standardized with cholesterol with lecithin, and the immune response they evoke is same in case of all these 4 cardiolipin using antigens. So, they are standardized, that is why they are called the standard test of syphilis. So, I can sum up again regarding this diagnostic procedure. This is very important for you. You have to remember during your practice life and every time. The non-specific tests are VDRL. The full name is Venereal Disease Research Laboratory. This laboratory is situated in New York. The other cardiolipin using tests are RPR, rapid plasma reagin, and trust antigen. The advantage of rapid plasma reagin over VDRL test is, in VDRL test we need microscope. We have to treat the serum, that is called preheating of the serum, at 56 degrees centigrade for 30 minutes. So, for VDRL the serum is preheated at 56 degrees centigrade for 30 minutes. If you ask me, sir, why this preheating is required, the answer is the different inhibitory factors are there in serum. So, if you want to neutralize the inhibitory factors of serum, we need this preheating. If you ask me, sir, give one example of these inhibitory factors, there are so many inhibitory factors in blood, but most importantly is IgM antibody. This VDRL antibody is IgG as well as IgM. This VDRL antigen is used in congenital syphilis. VDRL antigen is used for neurosyphilis. These are the advantage of this non-specific group, because they can be also used in neurosyphilis and congenital syphilis. Now, in case of birth passage infection, the fetus is immunologically becomes competent after 6 months. Before 6 months, maternal antibody is on. And what is the maternal antibody? It is IgG in nature. So, if we want to identify whether the fetus is suffering from congenital syphilis or not, we have to go for IgM test, not IgG. That is why we destroy the IgM and test again. The first test that covers the IgG, IgM. The second test after preheating, IgM is excluded, only IgG remains, and then we can calculate easily what is the amount of IgM. So, after 6 months, you have to monitor your patient fetus for syphilitic antigen. So, these are the importance of the cardiolipin antigen. And the FDA ABS is fluorescent tagged antibody absorbed. Why this particular word used as absorbed? Because the patient's antibody is treated with non-specific antigen, genus-specific antigen, that is derived from Retard's protein, and it is neutralized with Retard's protein. The remaining antigen remains as Nichols protein, which will be specific. So, we neutralize the non-specific antigen first, and the remaining is specific antigen, and we estimate the specific antigen then. The entire molecule is coated on the outer wall of the antibody. There is one other test is treponema pallidum immobilization test that is also done, and treponema pallidum hemoagglutination test is also used, where RBC is taken and tanned. What is tanning of RBC? Tanning of RBC means it is treated, the RBCs are treated with tannic acid, and then on their surface we can coat with other protein. So, this is the tanned RBC which is used for hemagglutination test, treponema pallidum hemagglutination tests. And I have mentioned that result is only treatment is only penicillin, penicillin and penicillin till date, because treponema usually till date is not possessing any plasmid. So, that is why it is till date sensitive to penicillin. The other diseases in spider sheets are Borrelia. It is responsible for relapsing fever, first 3 days fever followed by remission, and again after 7 days there is another type of fever due to another type of Borrelial antigen. The Borrelia is the largest variety of spider sheets. The identifications of Borrelia, Leptospira and treponema very easy by dark ground illumination microscopy. Spider sheets, especially treponema, can be identifiable by dark ground microscopy. I will show you the slide. And Leptospira usually contaminated from rat's urine, and often the disease is complicated with jaundice. Within first 2 to 3 days there is appearance of jaundice. So, pyrexia of unknown origin along with jaundice, a case where you can suspect leptospirosis. Usually the rat is usually responsible for contamination of water, drinking water, by their urine, usually in villages. So, rat is responsible for leptospiral disease, and different species are there. Leptospira ictero-hemorrhagica is the most important one. So, let us see the slides. Painless, the incubation period in case of syphilis is 9 to 90 days, 9 to 90 days, and this is a painless single indurated ulcer in compared to the chancroid of Haemophilus ducreyi. 1 to 14 days in the incubation period, it is painful, soft, usually multiple, purulent and bleeds easily. So, the same type of ulcers, one is soft, the other one is painless. Soft, painful and hard, painless. Very ancient disease, the syphilis. The name pallidum refers to the pale staining property and discovered by Skondin and Hoffman. The genus description is thin, flexible, elongated, spirally coiled helical bacilli. Spirally coiled, I will show you the picture. Include treponema, Borrelia and Leptospira. The treponemas are slender spider sheets with fine spirals having pointed ends. On either side, 2 discs are there in case of treponema pallidum, and the flagella they are attached with these discs, and within the cell structure, within the outer covering, they interdigitate at the middle part. So, when they interdigitate, their movement resulting in the cos 2 type of movement, extension and flexion movement, and to and fro or rotatory movement. These three types of movements are classical of Treponema pallidum. These two discs are very important, and with which these two discs the flagella are attached. So, this movement is called, these flagella, these are called endoflagella in nature. They are inside the cell, that is why they are called the endoflagella. Only few species are pathogenic to men, divided into two groups. Sexually transmitted Treponema pallidum, they are responsible for syphilis, and non-venereal treponematosis in Treponema partonui, endemicum and caratium. The Treponema endemicum is endemic in Middle East. Treponema partonui, known as jaws, usually seen in South Africa, and Treponema caratium, usually seen in America. These are non-venereal treponematosis, no sexual contact. Due to superficial skin to skin contact, these occurs. And where the only primary stage is not there, the disease starts from the secondary stage. Treponema, the genus pallidum, responsible for syphilis, endemicum for basal, partonui is os, and caratium is pinta. Borrelia burgdorferi is responsible for borreliosis, which is known as Lyme's disease, and recurrent is epidemic relapsing fever, and many other species are there known as endemic relapsing fever. One species of Borrelia is known as Borrelia vincenti, which results in gingivitis, oral ulcer, very foul smelling ulcer, and often it is contaminated with other anaerobic bacteria known as fusiform bacteria. Classical diagnosis is possible, identifying fusiform bacteria, pointed end bacteria, anaerobic in nature, in gram stain, along with spirochetes, along with Treponema. So, if we be able to identify this fusiform bacteria along with spirochetes, then it is clear case of, from oral ulcer, that is a clear case of Vincent's angina. The Vincent's angina is a very fatal disease. In case of dental surgeon, this is very important, and maxillofacial surgeon, they are often face these sorts of challenge. Leptospira, rat board disease. This is the periplasmic flagella structure, where you can see this is the disc where the flagella are attached, and this outer membrane and endoflagella, these are the endoflagella, and this is periplasm, and then cell wall. The between cell wall and outer membrane, this endoflagella is typically seen. This is Borrelia, the largest one is Borrelia. Leptospira, the spirals are more, very close spirals are seen in Leptospira. And Treponema, the end is pointed in Treponema. The general characteristics of Treponema, too thin to be seen with light microscopy in specimens stained with gram stain or GM stain. Motile spirochetes can be seen with dark field microscopy. In dark ground microscopy, you can see the movement of Treponema pallidum. Staining with anti-treponemal antibody is labeled with fluorescent dye. We take the smear from the patient's ulcer. Smear taking from the patient's ulcer is a challenge. From sterile saline soaked gauze is taken, and the ulcer is squeezed to take one drop of the extracted material on the slide, and a smear is prepared, and on that smear we add the staining material stained dye. As it is a fluorescent dye, the antigen antibody complex occurred, and then we can be able to identify with dark brown microscopy. We will show the picture. The epidemiology of Treponema pallidum is transmitted from direct sexual contact or from mother to fetus, and also by transfusion. The long incubation period during which time host is non-infectious, 10 to 90 days. Pathogenesis, the venereal, direct contact, blood transfusion, and transplacental. Spread Treponema pallidum penetrates through mucosa and abraded skin following sexual intercourse, and enter lymphatics and blood. Systemic primary lesions appear. The incubation period is 10 to 90 days, inversely proportional to the number of organisms inoculated. The mode of transmission is venereal. Non-venereal contact can occur among doctors and technicians. On the tip of the finger, the non-venereal contact can appear. The indurated ulcer can appear if you handle the case of syphilis without taking any precautions. So, it is a possibility. Clinical manifestations: among 30% of the patients who have sexual exposure with an infected partner develop syphilis. Clinically, patients suffering from syphilis pass through 4 stages if left untreated: primary, secondary, latent, and tertiary. Most important features: primary chancre, the latent is primary chancre, then condylomata, latent stage without any symptoms, and tertiary is neurosyphilis. These 4 you have to remember. It transmitted vertically. The newborn babies develop a congenital form of syphilis. The primary chancre, this is the nature of the male sex organ. In case of the female sex organ, the similar thing is usually seen by transvaginal examination on the labium majora, on the labium minora, where the frictions are more. Often we can see these sorts of lesions. It heals within 4 to 6 weeks. Following oral sex. The regional lymphadenopathy, the painless form, non-suppurative and often bilateral, may persist for months. If acquired by non-venereal mode, the primary syphilis is presented as direct contact, no primary stage now. If it is non-venereal mode, if syphilis is conducted without any primary stage is there. Non-venereal route, no primary syphilis. Directly to the secondary stage. Direct contact, extragenital, usually on the fingers. In case of clinicians, surgeons, the blood transfusion, the primary chancre does not occur. The secondary stage, you notice these type of spots all over the body. The skin and mucous membrane commonly affected. The primary lesion always heals spontaneously, but 6 to 12 weeks later the secondary lesions appear. These consist of red maculopapular rash anywhere on the body, including the hands and feet, anogenital region, axilla and mouth. There may be also syphilitic meningitis, chorioretinitis, hepatitis and nephritis. The secondary syphilis, condylomata lata, a warty growth. The mucocutaneous papules on the labia minora and majora. This is the situation. Ulcer on tongue. The latent syphilis, the absence of clinical manifestations. The positive serological tests are positive, but no clinical manifestations. The gametous lesion is for tertiary syphilis, the locally destructive granulomatous lesions on bone and skin. Neurosyphilis, cardiovascular syphilis. Mother to fetus transmission can lead to development of various congenital manifestations. Some of the infected features die, miscarriage results, and others are stillborn at term. The central nervous system anomaly can occur in congenital syphilis. Now, the diagnostic test for syphilis, microscopy, is with the dark field microscopy or DGI microscopy, the use of dark ground microscopy. Direct fluorescent antibody staining, I have mentioned that. Culture, it is not cultivable. Treponema pallidum is not cultivable. Serology, non-treponemal test, non-specific antigen, that is VDRL, venereal disease research laboratory test, rapid plasma reagent test, treponemal test. These are serology non-specific tests. And treponemal specific tests are fluorescent tagged antibody and microhemoglobin test for treponema pallidum, MHA-TP, another specific test. Most importantly, FTA, ABS and TPHA, these two tests are done. Dark ground microscopy, the slender structure, regularity in its spiral and pointed ends. The ends are pointed. So, it is classical of treponema pallidum. Borrelia is the largest spirochetes, and in case of leptospira, the tail ends are hooked. So, we can be able to identify on dark ground microscopy. Direct fluorescent staining is specific tests taken from body fluid, and silver impregnation test, as the endoflagella is very thin in structure, we have to make it heavy with silver impregnation test. So, how it is done? By silver impregnation method. Silver impregnation method of tissue is known as Levardity stain, and in smear is called Fontana stain. The classical picture of treponema, dark ground microscopy. Dark field microscopy of treponema pallidum. Non-treponemal tests known as reagin, and it is usually detected using cardiolipin antigen. A specific test, specific antibodies are detected by using treponema pallidum antigens. Another important thing is biological false positive. The biological false positive that occurs with the non-specific test. Biological false positive means the test is positive. In spite of that, there is no signs and symptoms of syphilis. Patient is not suffering from syphilis till that result is positive. There is no failure by the technicians, but still the test is positive. So, this is biological false positive. It occurs in 0.3 to 0.9% of cases. Biological false positive may be transient, may be persistent. In case of the biological false positive, we often search for the other interfering diseases or cross-reacting diseases like malaria, kala-jar and herpes virus infections. In this condition, leprosy also, the result is often becomes biologically false positive or cross-reacting antibodies are present. So, it is the important short note, biological false positivity in case of treponema pallidum test using cardiolipin antigen. This is test of syphilis by VDRL, the flocculation test. VDRL test is the example of flocculation test, agglutination and flocculation, where the soluble antigen is used. Here the soluble antigen is used, that is why it is a flocculation test. Give the example, one example of flocculation test, your answer will be VDRL test. The sensitivity in case of primary syphilis, it is 70% for VDRL, and secondary syphilis is 100%, tertiary 70%, specificity is only 77%. The significant titer of VDRL, the question is asked, what is the significant titer of VDRL? The significant titer of VDRL is more than 1:8. Sir, the significant titer of VDRL is 1:8, above which it is treated as positive. My question is why, sir? Why it is 1:8? Because non-treponemal VDRL exists in environment. Basal, pinta, carotenium, partinui, they also exist, and they are responsible for certain amount of titer present in blood due to this non-treponemal or non-venereal syphilis, non-venereal treponema. They are present in the environment, and for that reason the titer is slightly elevated. So, any titer above 1:8 is significant. If it is asked in the oral examination, what is the significant titer of VDRL? The significant titer is, sir, more than 1:8. What is STS? What is standard tests of syphilis? Standard test of syphilis means VDRL, RPR and trust antigen at least. Orthotoluidine test is also there. Anyway, trust antigen, at least 3 you have to remember. Why this group is called standard test of syphilis? Because their response is standardized by adding cholesterol and lecithin. Their immune response or immunity or reactivity is standardized. That is why they are included in the group of standardized tests of syphilis. When positive result found? When positive result found? After exposure, at least about after 2 weeks. After exposure, at least after 2 weeks, the positive VDRL test first seen. So, after 2 weeks after the exposure, the VDRL test is seen positive. What is the rate of biological false positive? That means patient is not suffering from syphilis, still the result is positive, and there is no failure on the technical part. So, that is called biological false positive. What is the rate of biological false positive? 0.3 to 0.9%, 0.3 to 0.9% cases. What type of antibody is related to biological false positive? Sir, IgM antibody is related to biological false positive. What are the difference between VDRL and RPR test? Which one you will prefer? Nowadays we perform RPR test, rapid plasma reagent test. Why? Because no microscopy, no preheating of the serum is required. That is why we use rapid plasma reagent test. But the disadvantage is that CSF cannot be tested. Disadvantage is that CSF cannot be tested. How CSF is tested and which method? Sir, VDRL is the method by which we can test CSF. Can you name any other test by which we can test CSF in case of congenital syphilis or neurosyphilis? Yes. Another test is FTA-ABS test, fluorescent tagged antibody absorb test. So, every alternate year there is a question on syphilis. The question is, describe the primary, secondary and tertiary nature of syphilis and design how you will identify the VDR, identify the treponema pallidum in patient sample. I have explained each and every step. Now it is your turn. And heart tick, they are responsible. Borrelia burgdorferi is responsible for Lyme's disease. There is antigenic variation, that is why there is a remission and once again the disease relapse. The several antigens are there. The important feature of Lyme's disease or Borrelia infection is the erythema marginatum, erythema migrans. Surrounding the tick bite, there is an area of redness. Surrounding the area of redness. This is the classical picture of Borrelia erythema migrans. Erythema migrans. Leptospira, often complicated with pyrexia of unknown origin and jaundice. The rat is responsible for leptospirosis. Thank you.
Our today's topic, benign leukocytic disorder. Basically, it is a theory class, but due to the shortage of time and for a huge syllabus, we have to cover this in our DOP session. And like this topic, many more topic will be also covered in such a way in DOP session. But basically, this is a theory topic. Okay. So, benign leukocytic disorder basically means all the things which we usually seen in the peripheral blood smear, we have to correlate these things with clinical history. আমরা peripheral blood smear এ যা যা কম্পোনেন্ট দেখব লিউকোসাইটের মধ্যে, সেই প্রত্যেকটা কম্পোনেন্টের either those components are in either high in count or low in count. We have to investigate the causes of this high count and low count basically. So basically either there might be an increase in total number of leukocyte, which is basic quantitative type, or there might be any abnormality in different components of leukocyte. That abnormality might be in neutrophil, that is granulocyte series, neutrophil, eosinophil, or monocyte macrophage series, and of course there might be abnormality in lymphocyte series. So if the quantity increases, if the total number of the WBC increases, it is known as leukocytosis. It is a proliferative type of abnormality, proliferative type of quantitative method of abnormality. If the total number decreases, it is known as leukopenia. It is regressive type of qualitative method of abnormality. So these are the nomenclature, and these are the standard formation, standard adult value from which we can designate a particular clinical picture, cytological or blood picture to be leukocytosis or leukopenia, etc. Like if the total leukocyte count is more than 11,000, it is known as leukocytosis. This is the standard form. আমরা যখন প্রতিদিন কাজ করি তখন এটাকে অ্যাডাল্ট ফর্মে, অ্যাডাল্ট মেলের ক্ষেত্রে এটাকে স্ট্যান্ডার্ড ধরে রাখি। অফকোর্স উই নো from birth to adult, the normal level of WBC varies. ইনফ্যান্টের ক্ষেত্রে, চাইল্ডের ক্ষেত্রে আপ টু 5 ইয়ার্স পর্যন্ত একটা লেভেল হবে, ইনফ্যান্টের ক্ষেত্রে একটা লেভেল হবে, চাইল্ডের ক্ষেত্রে একটা লেভেল হবে, অ্যাডাল্টের ক্ষেত্রে একটা লেভেল হবে। But basically we are considering here the only adult level. Okay. So if the count is more than 11,000, it is known as leukocytosis. If the count is less than 4,000, it is known as leukopenia. If the absolute neutrophil count is more than 7,500, it is known as absolute neutrophilia. And on the other hand, if its count is less than 2,000, it is known as neutropenia. Likewise, if the lymphocyte count is absolute lymphocyte count, absolute means it is not the percentage, it is the absolute count, the whole number. During the when we do the DC, আমরা কি করে, আমরা DC যখন কোনো একটা কম্পোনেন্টে করতাম তখন কি করে করতাম, পার্সেন্টেজে করতাম। The usually the normal WBC in normal blood picture, the neutrophil percentage usually 65 to 75%, lymphocyte 18 to 25%, eosinophil less than 10%, and monocyte usually less than 6%. But that was the percentage. But here these are the total number. এটা আমরা কোথা থেকে পাই? আমাদের কি কি মেথডে এই নাম্বারটা আসে? টোটাল WBC কাউন্টে কি করে পাই আমরা? আইদার নিউমাস চেম্বারে পাই, অথবা 3 পার্ট যদি সেল কাউন্টার থাকে সেখান থেকে পাই, অথবা 5 পার্ট সেল কাউন্টার থেকে পাই। সেখানে অ্যাকচুয়ালি একটা কলাম থাকে, সেখানেই আমরা absolute neutrophil count, absolute eosinophil count, এগুলো আমরা বুঝতে পারি। So absolute lymphocyte count is more than 4,000, it is known as lymphocytosis. On the other hand, if it is less than 1,500, lymphocytopenia. Eosinophil count more than 600, eosinophilia. Absolute monocyte count more than 1,000, monocytosis. And basophil more than only 100, it's known as basophilia. So there is an important term which is known as leukopenia with relative lymphocytosis. What do you mean by that term? Leukopenia with relative lymphocytosis. Leukopenia means in adult form the count should be less than 4,000. But here the lymphocyte count is high. But that is not the absolute neutrophil count, which is adjusted along that criteria. এরকম নয়, ওই ক্রাইটেরিয়াতে অ্যাবসলিউট লিম্ফোসাইট কাউন্ট ইজ মোর দ্যান কত ছিল ওখানে, কত দেখলাম 2000 সামথিং, কত ছিল 3000 2000 এরকম কিছু একটা, সেটা নয়। তাহলে রিলেটিভ কেন বলছি, সরি নয়, কারণ কি এখানে লিউকোপেনিয়া মানে কি টোটাল কাউন্ট 4000 এর বেশি, কিন্তু তার সাথে অ্যাডজাস্ট করছে না, বাট স্টিল উই আর calling it as a relative lymphocytosis. That means the normal percentage of lymphocyte is usually at the range of 18 to 25, but here the percentage is usually more than 25%. It might be around 40, 60, etc., etc. So it's a very important condition where the total leukocyte count is low, that is less than 4,000. But the lymphocyte count is here percentage wise is high. What are the conditions where we get lymphopenia with relative lymphocytosis? Aplastic anemia, some viral infection like AIDS, tuberculosis, infectious mononucleosis, mumps, measles, rubella, etc. Some autoimmune infection, autoimmune disease like autoimmune thyroiditis, some collagen vascular disease, SLE, rheumatoid arthritis. These are causes of leukopenia with relative lymphocytosis. কিছুদিন আগেই যেটা প্যান্ডেমিক হয়েছিল COVID-19, also important cause of leukopenia of relative lymphocytosis. Any viral infection, after some time there will be depletion of total count, but relative lymphocyte count is high. Anyway, so next we are coming to the neutrophil. What are the causes of neutrophilia? Some physiological cause and some pathological cause. Of course, we know that during the pregnancy the neutrophil count is usually high. Any bacterial infection, especially the gram positive, ওইখানে বসে আছিস কেন, এদিকে আয়, আমার পিঠ দেখতে পাবি আর কিছু দেখতে পাবি না, এদিকে আয়, ফ্যান নেই তাও বস, এখানে আয়। gram positive cocci, usually the bacterial infection is the most important bacterial infection where we can get the neutrophilia. Any kind of tissue destruction, any acute inflammation. Tissue destruction means there will be acute inflammation. Vasculitis, neutrophilic vasculitis, আমরা যখন vasculitis এর প্রপার চ্যাপ্টারে পড়ব তখন এটা জানতে পারবো। Acute hemorrhage and some hematological malignancies like আজকেই দেখাবো কিছু কিছু স্লাইড। আজকে ক্লাস কিন্তু শোনো একটা কথা বলেছি, ডিওপি ক্লাস 2 ঘন্টাই হবে, 2 ঘন্টার আগে চলে গেলে তোমরা ক্লাস নাও করতে পারো, আমি 2 ঘন্টাই ক্লাসে থাকবো, কারণ থিওরি আমি 1 ঘন্টা নেব, প্র্যাকটিক্যাল 1 ঘন্টা, মানে স্লাইড দেখানো 1 ঘন্টা, এটা বরাদ্দ। 2 ঘন্টার আগে চলে গেলে দ্যাটস আপন ইউ, কেউ রিকোয়েস্ট করবে না 2 ঘন্টার আগে ক্লাস অফ করার জন্য আমাকে। solid tumor, acute hemolysis, and of course the hematological malignancies like CML, myeloproliferative disorder, and Hodgkin lymphoma. Second, these are the reaction when of neutrophil when there is severe or dreaded gram-positive cocci infection. These are the morphological features of neutrophil we can get in a septicemic condition or high acute inflammatory condition. These are shift to left, number 1. Second, presence of toxic granule. আজকেই দেখাবো. Third, Dohole bodies. And fourth, cytoplasmic vacuoles. These are 4 important features of acute inflammatory reaction of neutrophil. Shift to left, toxic granule, Dohole body, cytoplasmic vacuole. একে একে আসি. Shift to left. আমরা normally up to band stage normal peripheral blood smear এ neutrophil এর maturation দেখতে পাই. But if there is any high turnover যেখানে নিউট্রোফিলকে অনেক বেশি এঙ্গেজ হতে হচ্ছে আমাদের ইমিউন সিস্টেমে, তখন কি হচ্ছে অনেক ইম্যাচিওর ফর্ম, প্রিকারসর ইম্যাচিওর ফর্ম তারা আমাদের ব্লাডে চলে আসছে. দিস ইজ নোন অ্যাজ শিফট টু লেফট. ওকে, লাইক উই ক্যান গেট, কনসেন্ট্রেট করো, ওরা ওনাদের মতন কাজ করবে. We can get myelocyte, metamyelocyte, even promyelocyte, but not blast. Mind it, not blast. Infection কতদূর হচ্ছে, তার সিভিরিটিটা কতটা, হাই টার্নওভার কতটা হচ্ছে, তার উপরে বেসিক্যালি নির্ভর করবে যে ইম্যাচিওর ব্লাড সেল কতদূর পর্যন্ত আমরা ব্লাড সেলে দেখতে পাবো. যদি টার্নওভার রেট প্রচুর হাই থাকে তাহলে প্রোমাইলোসাইট পর্যন্ত আমরা দেখতে পারি. সো ইট ক্যান বি গ্রেডেড আপ টু সিভিয়ার, মডারেট অর মাইল্ড. ফার্স্ট. সেকেন্ড, leukoerythroblastic reaction. This is a peculiar type of blood picture. এখানে এসো, এদিকে এসো, তোমরা এদিকে এসো প্লিজ, ওদেরকে কাজ করতে দাও আমাদেরকে. এদিকে একটা leukoerythroblastic reaction. This is a peculiar type of blood picture where not only the precursor leukocyte series cell we can get within the blood, but also the nucleated RBC we can get in peripheral blood smear. So precursor of WBC series as well as precursor of erythroid series, erythroid and myeloid, and of course lymphoid even. So this is a peculiar condition we get not only the immature WBC but also the immature RBC. বুঝলে? But to understand the etiology of this condition, we have to do some bone marrow study. So what are the conditions where we can get the leukoerythroblastic reaction? একটাই ফান্ডা মনে রাখবেন, যখনই বোন ম্যারোতে কোনো আউটসাইড এজেন্ট এসে বোন ম্যারোর নর্মাল সেলগুলোকে জায়গা দিচ্ছে না তার পলিফারেশনের জন্য, নর্মাল সেলগুলো জায়গা নেপে বাড়িয়ে পালিয়ে যাচ্ছে জায়গা থেকে. তোমার হোস্টেলে যদি বাইরে থেকে এখন ছেলেরা এসে ঢুকে যায় তাহলে তোমার হোস্টেল, তোমাদের যাদের তোমার বেডে তুমি থাকতে পারবে না, সেখান থেকে বেরিয়ে চলে যাবে. দিস ইজ দ্য কন্ডিশন. Any outside agent outside to the bone marrow basically, if comes within the bone marrow, it will show some leukoerythroblastic reaction. Of course, like metastatic deposit of any kind of carcinoma or sarcoma in bone marrow, or if there is any storage disorder involving the bone marrow like Niemann-Pick, Gaucher's, etc., etc., or if there is any hematological malignancy, infiltration of marrow by hematological malignant cell in myeloproliferative disease, myelofibrosis, lymphoma, leukemia, etc., etc., or infective condition যদি TB excessive growth হয়. This is a condition where small foci all over the body involving also the bone marrow, excessive growth of TB is occurring. everywhere in our body, like miliary tuberculosis. These are the condition of leukoerythroplastic reaction. মনে থাকবে। নেক্সট কি বলেছিলাম, আর একটা হচ্ছে টক্সিক গ্র্যানুল। নর্মালি পরে দেখাবো, জেনে রাখো, নর্মালি আমরা নিউট্রোফিলের মধ্যে যে গ্র্যানুলসগুলো দেখতে পাই, দিজ আর পার্পলিশ কালার ফাইন গ্র্যানুল। বাট ইফ দেয়ার ইজ এনি আন্ডারলাইং septic condition or inflammatory condition, acute inflammatory condition, these granules become coarse, and that will as such as coarse that the nuclear outline of neutrophil cannot be established thoroughly under microscope. In extreme form of toxic granule formation, grade 4 or grade 3 toxic granule formation, even the presence of toxic granule can be graded up to grade 1, 2, 3, 4. In 3 and 4, the nuclear outline cannot be established clearly under microscope. কি স্লাইড যা আছে অনেক আছে, যে কোনো খুশি, ঠিক আছে। দিস ইজ টক্সিক গ্র্যানুল। অ্যান্ড সেকেন্ড, ওখানে কিছু হচ্ছে না, এখানে হচ্ছে, ওদেরকে কাজ করতে দেন। Second, Dohle bodies. If there is any inflammatory condition where the cell turnover is high, or there is ongoing phagocytic activity of neutrophil is occurring everywhere in body. Excessive phagocytic activity হচ্ছে neutrophil খেয়ে নিচ্ছে, খেয়ে নিয়ে মাল মশলাগুলো কোথায় জমা হবে? within the cytoplasm. সেই সাইটোপ্লাজমের মধ্যে একটা ইনক্লুশন থাকবে। দিস আর নাথিং বাট দ্য রেমনেন্টস অফ রেটিকুলার এন্ডোথেলিয়াম। দিস ইজ নোন অ্যাজ ডোহলে বডি, ঠিক আছে। অ্যান্ড ইন সাম কেসেস দোজ phagolysosome can be appreciated under microscope as cytoplasmic vacuoles. ডোহলে বডি হচ্ছে ওই ফ্যাগোসাইটিক সেল যেগুলো হচ্ছে এন্ডোপ্লাজমিক রেটিকুলামের মধ্যে ইনক্লুশন হয়ে আছে, সেগুলোকে ডোহলে বডি বলে। বাট ওই যে ফ্যাগোলাইসোজোম তৈরি হয়েছিল, আমরা অ্যাকিউট ইনফ্লামেশনে পড়েছিলাম, সেগুলোকে আন্ডার মাইক্রোস্কোপ উই ক্যান অ্যাপ্রিশিয়েট অ্যাজ cytoplasmic vacuole. These are features of acute inflammatory condition, extremely acute. So there are some important mechanism for neutropenia, that is neutrophil count is decreasing. Might be due to ineffective erythropoiesis, normally bone marrow মধ্যে neutrophil তৈরি হচ্ছে না, or excessive destruction in the peripheral organ, or there is suppression of hematological progenitor cell via some outside agent, or if there is some Dravik effect. চারটে কি কি? ইনএফেক্টিভ এরিথ্রোপাইসিস, প্রোডাকশন প্রচুর হচ্ছে বাট ম্যাচুরিটি পাচ্ছে না সেলগুলো, লাইক মাইলোপলিফারেটিভ ডিসঅর্ডার, মাইলোডিসপ্লাস্টিক সিন্ড্রোম, মেগালোব্লাস্টিক অ্যানিমিয়া। মেগালোব্লাস্টিক অ্যানিমিয়াকে আমি ইনএফেক্টিভ এরিথ্রোপাইসিস কেন বলছি? কারণ নিউক্লিয়ার সাইটোপ্লাজমিক ম্যাচুরেশন অ্যাসিনক্রোনি হয়। Why? Because there is nutritional deficiency of vitamin B12 and folic acid. Normal maturation of DNA is not occurring here. সময় নষ্ট হলো। এটা আমি তাড়াতাড়ি চাইছিলাম, এই জন্যই যে তোমাদের মানে কোনো একটা পার্টিকুলার ফোকাস করে দেখানোটা চাপের, মানে কারণ তোমাদেরকে একটা পার্টিকুলার মানে ফোকাস করে দেখাতে হবে। তো এক একটা মাইক্রোস্কোপে দেখলে তোমরা কি দেখছো না দেখছো আমি বুঝতে পারছি না। অ্যাকচুয়ালি পিজিতে মানে আমি যেখান থেকে পড়েছি এইভাবে ক্লাস নেওয়া হয়, ওখানে আমাদের চারটে আছে। এটা আমি অনেক করে বলে করে স্যারকে করে রিকোয়েস্ট করে সেন্ট্রাল ল্যাবে আছে। সেন্ট্রাল ল্যাবে আছে তো, বাট দেয়ার আর 4 মেকানিজম অফ নিউট্রোপেনিয়া। প্লিজ এবার গল্প না না অনেক হয়েছে। দেয়ার আর 4 মেকানিজম অফ নিউট্রোপেনিয়া। 1, ইনএফেক্টিভ এরিথ্রোপয়েসিস বললাম। সেকেন্ড হচ্ছে এক্সেসিভ ডিস্ট্রাকশন, পেরিফেরাল ডিস্ট্রাকশন। আইদার দেয়ার মাইট বি সিকুয়েস্ট্রেশন ইন দ্য পেরিফেরাল lymphoid organ like in spleen, liver, etc., etc., or in some cases if there is autoimmune condition where auto antibody are produced against the neutrophilic antigen. Anti-neutrophilic antibody, which is although non-specific but very sensitive marker of SLE. তার ফলে কি হয়, SLE তে এইডস, SLE এগুলোতে, ঠিক আছে, সেখানে কি হয়, নিউট্রোফিল অটো ইমিউন কন্ডিশন, বাট সেখানে নিউট্রোফিলের ড্যামেজ হচ্ছে, ডিস্ট্রাকশন হচ্ছে। এছাড়া সাম ড্রাগস which are affecting the myeloid progenitor cell, and the myeloid progenitor cell, the normal count has been decreased, like sulfonamide, alkylating agent, etc., etc., and some infection like typhoid, brucellosis, AIDS, malaria, or some external subject invading the marrow like tumor invasion. ক্লিনিক্যালি কি দেখবো, নিউট্রোফিলের মেইন কাজ হচ্ছে ফ্যাগোসাইটোসিস করা। সো রিকারেন্ট গ্রাম পজিটিভ অর গ্রাম নেগেটিভ কক্কাই অর ব্যাসিলার ইনফেকশন, recurrent infection. We can grade these things, neutropenia as mild, moderate, severe. If count is 1500 to 1000, it is known as mild, moderate 1000 to 500, and less than 500 is severe. Eosinophilia. Eosinophilia, the absolute count is more than কত ছিল 2500. Okay, so mainly 3 conditions you have to remember for your undergraduate topic as a short note and as a theory for peripheral eosinophilia. These are Loeffler syndrome, second tropical eosinophilic syndrome, and third idiopathic hypereosinophilia syndrome. And one important condition which is closely related with high eosinophil count, which is bacterial bronchial asthma. Loeffler syndrome কি সেটা, if there is some parasitic infection, especially Ascaris lumbricoides or Stranguloid stercolis, the body immune system produce some interleukins like interleukin 4, interleukin 5, and these interleukins produce much amount of eosinophil, and it is associated with high Ig count and some clinical features like non-specific infiltrate in chest, which is shown in the chest X-ray as a transient lung infiltrate. Patient clinically present as nocturnal cough, dry cough, wheezing, etc. And তোমরা যখন মাইক্রোবায়োলজিতে পড়বে, Ascaris lumbricoides is the most common condition, most common agent of Loeffler syndrome. Second, tropical eosinophilia syndrome, microfilaria of Wuchereria boycopteri and Brugia malloy, when they invade into the circulation, especially in lymphatic channel of lung, around that microfilaria, invasion of eosinophil is extremely high. It is known as tropical eosinophilia syndrome. And there is, and third condition is hypereosinophilia syndrome, high eosinophil count, but there is no diagnosable underlying etiology, মানে কেন হচ্ছে কেউ ডায়াগনোস করতে পারছে না, always associated with the high Ig count and etc., etc., and high eosinophil count. Other কিছু condition আছে like bronchial asthma, if it is type 1 due to type 1 hypersensitivity reaction, which is atopic type of bronchial asthma, or in atopic rhinitis or sinusitis, there will be high eosinophil count. Medicine তোমরা পড়বে Hampton Strad. One of the important component of Hampton Strad is eosinophilia. Other কি ছিল? কিছু প্যারাসাইটিক ইনফেকশন ছিল, লাইক স্টারকয়েলারিস টঙ্গোলয়েডিস, যা যা বললাম আর কি। নেক্সট কামিং টু বেসোফিলিয়া। যখনই বেসোফিলিয়া আসবে পয়েন্ট, জাস্ট আর কিছু মনে না রাখো, একটা কন্ডিশন অলওয়েজ মনে রাখবে, সেটা হচ্ছে ক্রনিক মাইলয়েড লিউকিমিয়া। আমরা বেসোফিল কখনোই পেরিফেরাল ব্লাড স্মিয়ারে দেখতে পাবো না। যখনই আমি বেসোফিল ক্রনিক মানে দেখতে পাবো, ইউ হ্যাভ টু হ্যাভ রুল আউট ক্রনিক মাইলয়েড লিউকিমিয়া। আমরা যখন লিউকিময়েড রিঅ্যাকশনের সঙ্গে ক্রনিক মাইলয়েড লিউকেমিয়াকে ডিফারেন্সিয়েট করব, one of the important differentiating feature will be basophil count will be high in chronic myeloid leukemia. Basically chronic myeloid leukemia তিনটে স্টেজ থাকে: chronic stage, accelerated stage and blast crisis. কেন ডিফারেন্সিয়েটেড করা হয়? Because the blast level in chronic, accelerated and blast crisis stages are different. Like if I classify the CML according to the stages, it will be chronic, পরের দিনই পড়াবো এটা, chronic, accelerated and blast crisis. কি করে ডিফারেন্সিয়েট করে জানো? অবশ্যই আছে, সাইটোজেনেটিক স্টাডি আছে, ডিফারেন্ট স্টেজে ডিফারেন্ট সাইটোজেনেটিক চেঞ্জ হয়, ডিফারেন্ট মিউটেশন হয়, few mutation occurring in chronic stage, few newer mutation occurring in accelerated stage, but that is completely different issue. এটা তোমাদের লেভেলে জানতে হবে না। তোমাদের যেটা জানতে হবে, যখন পেরিফেরাল ব্লাড স্মিয়ার দেখবো, পেরিফেরাল ব্লাড স্মিয়ারে blast and basophil level. If the blast is less than 5%, it is chronic. If it is 5 to 10%, it is accelerated. If it is more than 10% or up to 10 to 20%, and up to 20%, it is blast crisis. Even it may go more than 20% also. And if the basophil count is more than 10%, it is chronic. And in blast, accelerated and blast crisis, it is more than 10%, up to any number. Newer WHO তে এই পার্সেন্টেজটা চেঞ্জ হয়েছে, আপডেটেড পার্সেন্টেজটা আমি পরের দিন বলবো। এটা ইন জেনারেল মনে করা হয় এরকম। WHO যেটা 2016 এ ছিল, সেটা এই লেভেল ছিল। 2022 তে WHO নতুন মডিফিকেশন হয়েছে, সেখানে পার্সেন্টেজ চেঞ্জ হয়েছে। আমি চাইবো তোমরা নতুন মডিফিকেশনটাই মনে করো, বাট সেটার আগে আমি আগে পড়াই, তারপর বলবো। সো ফান্ডা হচ্ছে, বেসোফিল যখন তুমি পাবে, তখন অবভিয়াসলি ইউ হ্যাভ টু রুল আউট ক্রনিক মাইলয়েড লিউকেমিয়া। হলো? এছাড়া আর কিছু কন্ডিশন আছে, পাঁচটাই মনে রাখবে। আলসারেটিভ কোলাইটিস, ইনফ্লামেটরি বাউল ডিজিজ, দু রকমের হয় ইনফ্লামেটরি বাউল ডিজিজ, আলসারেটিভ কোলাইটিস এন্ড ক্রনস ডিজিজ, সেখানে পাবে। রিমাটয়েড আর্থারাইটিসে পাবে, আর ডায়াবেটিস মেলাইটাসে পাবে। ডেফিনিটলি ডায়াবেটিস মেলাইটাসে কিছু, সব কন্ডিশনে নয়, কিছু নেফ্রোপ্যাথি এবং নিউরোপ্যাথিতে এটা পাওয়া যায়। এটা ডায়াবেটিস মেলাইটাসে যদি কখনো আসে কন্ডিশন, আমি তখন মনে করি দেবো। এছাড়া ওকে, so these are all qualitative abnormality of leukocyte. Now quantitative abnormality. Quantitative abnormality might be acquired or inherited. তোমাদের চারটে জিনিস কোয়ান্টিটিভ অ্যাবনরমালিটিতে মনে রাখতে হবে। তার মধ্যে অ্যাকোয়ার্ড মরফোলজিক্যাল অ্যাবনরমালিটির মধ্যে তিনটেই বলে দিয়েছি। অ্যাকোয়ার্ড কেন বলছি? কারণ দিস চেঞ্জেস আর অকারিং অ্যাট দ্য টাইম অফ ইনফ্লামেশন। So these are acquired. But if it is inherited, then these four, mainly four abnormality, এগুলো তোমাদের অ্যাকচুয়ালি আসবে না, বাট ফর দ্য সেক অফ ইউর থিওরি তোমাদের জেনে রাখতে হবে। পেলগার হিউট অ্যানোমালি তোমাদেরকে দেখিয়েছি কখনো? ওই ব্যাচে দেখিয়েছিলাম। এটা একটা জেনেটিক কন্ডিশন যেখানে বেসিক্যালি ইট ইজ অ্যাসোসিয়েটেড উইথ দ্য myeloproliferative disease and AML, but in some cases of myelodysplastic syndrome and AML, but in some cases of extreme turnover in myeloproliferative disease like in CML, chronic myeloid leukemia, there might be some Pelgar-Hugh type of anomaly. So in Pelgar-Hugh anomaly ki pabo amra? Lack of nuclear maturation. So the segmentation of nuclei is incomplete. So either that might look as indented or round nuclei or two segment nuclei. Two segments are joined with each other with coarse chromatin. Pelgar-Hugh anomaly দেখাবো, ডেফিনেটলি দেখাবো। এইটা আসতে পারে, বাট আসবে না তোমাদের। আচ্ছা, এল্ডার-রেইলি অ্যানোমালি, এটা হাল্লার আর হান্টার সিনড্রোমে পাওয়া যায়, ডেফিনেটলি আসবে না। কি হবে? গ্র্যানিউলগুলো যেগুলো থাকবে সেগুলো কোর্স ডার্ক কোর্স গ্র্যানিউল, কি আইদার লিম্ফোসাইটে পেতে পারি অথবা নিউট্রোফিলে পেতে পারি। এছাড়া মে-হেগলিন অ্যানোমালি আসবেই না, পড়াচ্ছি না। চেইডাক-হেইগ্যাসি সিনড্রোম, চেইডাক-হেইগ্যাসি সিনড্রোমকে আমি পরে বলছি, কারণ এই চারটে ইনহেরিটেন্ট abnormality of functional disorder of lymphocyte neutrophil is very important for your syllabus, পরে পড়াচ্ছি। তার আগে দেখে নাও টক্সিক গ্র্যানিউল যেগুলো বলেছিলাম, কোর্স গ্র্যানিউল, ডার্ক পার্পলিশ or bluish color, ডোহলে বডি একদম নিচে একটা ইনক্লুশন, these are segmented inclusion, purplish color, hyper segmented neutrophil, more than 5 lobe, 5%, more than 5%, 5 lobe or 6 to any number, একটা হলেও hyper segmented। Pelgar-Hugh anomaly, এইটা লার্জ কোর্স গ্র্যানুলিন, চেইডাক-হেইগ্যাসি পরে বলছি। ডিসঅর্ডার অফ দ্য ফাংশন, জাস্ট চারটে ডিসঅর্ডার তোমাদেরকে মনে রাখতে হবে, চারটে ডেফিনেটলি মনে রাখবে, কারণ এগুলো শর্ট নোট আসে। চারটে মনে রাখবে, ঠিক এরকম করেই মনে রাখবে কি কি প্রবলেম হয়, কোথায় কোথায় হয়। চারটেই হচ্ছে নিউট্রোফিলের ফাংশনাল ডিসঅর্ডার। ফার্স্ট LAD1, সেকেন্ড LAD2, থার্ড ক্রনিক গ্রানুলোমাটাস ডিজিজ, অ্যান্ড ফোর্থ চেইডাক-হেইগ্যাসি সিনড্রোম। ঠিক আছে? LAD1, leukocyte adhesion deficiency type 1. So this is an abnormality of leukocyte adhesion. Abnormality for LAD1 is beta 2 integrin. এইবার ইনফ্লামেশনের ফার্স্ট চ্যাপ্টারে চলে যাও। ইন্টিগ্রিন কোন কাজে লাগে, কোন সময় লাগে তোমরা বলো? পরে, এক্স্যাক্টলি পরে, বাট ইন্টিগ্রিন কোথায় কাজে লাগে? What are the steps of acute inflammation? একদম ফার্স্ট স্টেজ কি? Transient vasoconstriction, next vasodilation, next increased vascular permeability, next stasis, next rolling, then margination, then rolling, then adhesion, then chemostaxis, next transmigration, next oxidative burst, before oxidative burst phagolysosome formation, chemotaxis বললাম, oxidative burst that is phagolycosis, then oxidative burst killing। ঠিক, তাহলে এতগুলো স্টেজ আছে। কোন স্টেজে অ্যাডিশনটা লাগে? মার্জিনেশন, অ্যাডিশন। বিটা 2 ইন্টিগ্রিন abnormality ডিউ কজিং ল্যাড। ক্লিনিক্যালি হবে অবশ্যই রিকারেন্ট ডব্লিউবিসি কাজ করতে পারছে না, রিকারেন্ট ইনফেকশন হবে। বাট সেকেন্ড ইম্পর্টেন্ট, ডিলেড আম্বিলিকাল সেপারেশন। ইন্টিগ্রিনের একটা বড় কাজ থাকে আম্বিলিকাল কর্ডকে ডিফারেন্সিয়েট করতে, মানে ছেড়ে যেতে। টাইপ 1 ল্যাড। টাইপ 2 লিউকোসাইট অ্যাডহেশন ডেফিসিয়েন্সি due to what? Due to Sial-Lewis X receptor deficiency in two type of selectin, p-selectin, e-selectin. p-selectin কোথায় থাকে? প্লেটলেটে। e-selectin এন্ডোথেলিয়াল সেলে। একই রকম থাকবে, শুধু ডিলেড আম্বিলিকাল কর্ড সেপারেশন হবে না। ঠিক। থার্ড, ক্রনিক গ্রানুলোমাটাস ডিজিজ। এগুলো তোমরা পড়েছো, বাট তাও একবার মনে করছি। ক্রনিক গ্রানুলোমাটাস ডিজিজ কি হয়? এক্স্যাক্টলি, ফক্স জিন। দারুণ। ফক্স জিনের ডেফিসিয়েন্সি কি হয় সেখানে? কি abnormality? NADPH is not acting, so the oxidative burst is not occurring, so catalase positive microorganisms are not get killed, so it will cause a chronic inflammatory condition, chronic granulomatous condition, chronic granulomatous disease. দুটো টেস্ট ইম্পর্টেন্ট, একটা পেরিফেরাল ব্লাড স্মিয়ারে দেখতে পাবো, সেটা হচ্ছে কোর্স গ্র্যানিউল দেখতে পাবো, কোর্স ব্লুইশ গ্র্যানিউল, বাট দিজ আর নট টক্সিক গ্র্যানিউল। আর একটা কি দেখতে পাবো? একটা টেস্ট পজিটিভ হবে, যাকে বলা হয় নাইট্রো ব্লু টেট্রাজোলিয়াম টেস্ট, এনবিটি, নাইট্রো ব্লু টেট্রাজোলিয়াম টেস্ট। এত কিছু লিখছি না, that NBT test will be positive. আর 4 নম্বর শর্ট নোট হচ্ছে চেইডাক-হেইগেসে সিনড্রোম। লিস্ট বলে একটা জিন আছে, LYST, লিস্ট জিনের মিউটেশন হয়। কি হবে তাতে? ফ্যাগোলাইসোজোম ফর্মেশন ইজ abnormal, and that লিস্ট জিন দুটো জায়গায় আছে, দুটো কাজে সাহায্য করে। এক, মেলানোসাইটিক ডিফারেন্সিয়েশনে, আর ciliary movement of cochlea, and 3 নম্বর একটা কাজ আছে, সেটা হচ্ছে maturation of thrombocyte. So subsequently তিনটে প্রবলেম হবে। মেলানোসাইটের ম্যাচুরেশন অ্যাবনরমালিটি হচ্ছে মেলানোসাইট তৈরি হচ্ছে না, বাচ্চা অ্যালবিনিজম নিয়ে জন্মাবে। হলো সেকেন্ড পয়েন্ট, অ্যাবসেন্স অফ ciliary motility of cochleary cell, so sensorineural hearing loss, and maturation of thrombocyte is abnormal, so thrombocytopenia. Monocyte macrophage system, monocytosis কোথায় পাওয়া যায়? মনোসাইট লেভেল। এটাও সেম, মোস্ট কমনলি হচ্ছে ইনফেকশনের ক্ষেত্রে ম্যালেরিয়াতে মনোসাইট লেভেল খুব হাই হয়। আর আরেকটা খুব মনে রাখবে, এই কথাটা অবশ্যই মনে রাখবে, ভিসেরাল লিশমেনিয়াসিস কালা জ্বরে, ডার্মাল অর ভিসেরাল লিশমেনিয়াসিস কালা জ্বরে। সো ম্যালেরিয়া, কালা জ্বর। আর কিছু মনে রাখো না, এই দুটো পয়েন্ট মনে রাখবে। সেকেন্ড হচ্ছে ইনফেকশিয়াস কজেস, সার্কোইডোসিস অ্যান্ড ইনফ্লামেটরি বাউল ডিজিজ। থার্ড, সাম হিমাটোলজিক্যাল কন্ডিশনস, ক্রনিক মাইলোমোনোসাইটিক লিউকিমিয়া, মোনোসাইট কথাটা আছেই, অ্যাকিউট মাইলয়েড মাইলোমোনোসাইটিক লিউকিমিয়া আর ক্রনিক মাইলোমোনোসাইটিক লিউকিমিয়া, এই দুটোতে। অ্যান্ড সাম কোলাজেন ভাস্কুলার ডিজিজ লাইক SLE, rheumatoid arthritis, ulcerative colitis, etc. Next, lymphocytic abnormality. Of course, এখানে যেগুলো কথা বলা হয়েছে সবকটাই benign condition, these are not malignant one. Any viral condition is associated with the lymphocytosis. That might be absolute, might be relative. Might be absolute, might be relative. কথা দুটোর মানে এখন বুঝে গিয়েছো। লাইক ইনফেকশিয়াস মনোনিউক্লিওসিস একটা প্রবলেম হয়, উই হ্যাভ টু ডিফারেন্সিয়েট ইনফেকশিয়াস মনোনিউক্লিওসিসে যে চেঞ্জ হয় লিম্ফোসাইটে, তার সঙ্গে হচ্ছে লিম্ফোব্লাস্টের। একটাকে বলা হয় অ্যাক্টিভেটেড লিম্ফোসাইট, একটাকে বলা হয় লিম্ফোব্লাস্ট। কি পার্থক্য পরে বলবো। এছাড়া chronic infection of course tuberculosis, brucellosis etc. and some acute infection like whooping cough. acute infection এর নিউট্রোফিল সবসময় বেশি থাকে, বাট এটা একটা এক্সেপশন যে হুপিং কফে আমরা লিম্ফোসাইটোসিস পাচ্ছি। আর কি লিম্ফোপেনিয়া, লিম্ফোসাইটোপেনিয়া বেসিক্যালি, অফকোর্স এইডস, এইচআইভি ইনফেকশন, এইচআইভি রিসেপ্টরই আছে লিম্ফোসাইটের উপরে, CD4 অ্যান্ড CCX5 পড়েছো বোধহয়, এইডস তোমাদের হয়ে গেছে বোধহয় ক্লাস, হয়নি? এইচআইভি প্যাথোলজিতে হবে CC4 অ্যান্ড CXCR5, দুটোই থাকে লিম্ফোসাইট অ্যান্ড মনোসাইট ম্যাক্রোফেজ সিস্টেমের উপরে। সো ড্যামেজ ডেফিনেটলি লিম্ফোসাইটের উপরেই হবে, CD4 CD8 কাউন্ট লো হয়। অ্যান্ড অফকোর্স হজকিন লিম্ফোমা, কেন হয় হজকিন লিম্ফোমাতে, যখন হজকিন লিম্ফোমা পড়াবো তখন বলবো। আর যদি অ্যালকাইলেটিং এজেন্ট, রেডিওথেরাপি, কেমোথেরাপি চলে তাহলে হবে। স্টেরয়েডের একটা ইম্পর্টেন্ট অ্যাক্টিভিটি হচ্ছে লিম্ফোসাইট এমনি টোটাল WBC কাউন্টকেই কমিয়ে দেওয়া। সো দিস ইজ ওয়ান অফ দ্য ইম্পর্টেন্ট কন্ডিশন। আমরা ফার্মাকোলজিতে যখন স্টেরয়েড পড়বে তখন দেখবে যখনই কোনো অ্যাকিউট কন্ডিশন হয় তখন তাকে সাবমার্স করার জন্য স্টেরয়েড অ্যাক্টিভিটি হয়। আর হচ্ছে সাম সেন্ট্রাল নার্ভাস সিস্টেম প্রেশার যদি পেতে চাই তাহলে অ্যাকচুয়ালি লিম্ফোসাইটোপেনিয়া হয়। এটাই আমার লাস্ট টপিক, বাট ভেরি ভেরি ইম্পর্টেন্ট টপিক। তোমাদের অ্যাকচুয়ালি যদি দুটো টপিক বিনাইন লিম্ফোসাইটিক লিউকিমিয়া বিনাইন লিম্ফোসাইটিক ডিসঅর্ডার থেকে পরীক্ষায় আসে তাহলে সেটা দুটোই আসবে, দুটো স্লাইড অ্যাকচুয়ালি আসবে। আমি নিয়েও এসেছি স্লাইড দুটো, ভালো করে দেখে নেবে। চিনবে স্লাইডটা, সেটা হচ্ছে একটা লিউকেময়েড রিয়াকশন আর একটা হচ্ছে পেরিফেরাল ইওসিনোফিলিয়া। তোমাদের ব্লাডে বেশি স্লাইড থাকবে না, আর স্লাইড আর আগের মতন কিন্তু ভার্চুয়াল দেওয়া হবে না, কারণ তোমাদেরকে এখন কিন্তু মাইক্রোস্কোপেই দেখানো হচ্ছে। সো ডেফিনেটলি তোমাদেরকে স্লাইডই দেখানো হবে, আন্ডার মাইক্রোস্কোপ দেওয়া থাকবে, তোমাদেরকে ডায়াগনোস করতে হবে। সো বিনাইনের মধ্যে দুটো কন্ডিশন তোমাদেরকে দেখতে হবে, একটা চিনতে হবে, একটা হচ্ছে লিউকেমিয়াড রিয়াকশন আর একটা হচ্ছে পেরিফেরাল ইওসিনোফিলিয়া। Leukemioid reaction means it is a reactive condition where immature blood cells, immature WBCs are present in the peripheral blood smear and they simulate the leukemic condition, malignant condition. Okay, so they may look like myeloid leukemia or may look like lymphoid leukemia. কেন? যদি WBC প্রচুর হাই হয়ে যায় তাহলে মাইলয়েড সিরিজের মতন, মাইলয়েড লিউকেমিয়ার মতন লাগবে, দেখতেই পাবে, বুঝতেই পারবে যে যখন মাইক্রোস্কোপে দেখতে পাবে তখনই ডিফারেন্সিয়েট করতে হবে তোমাকে। লাইক ওই যে বলেছিলাম টক্সিক গ্র্যানুল পাওয়া যাচ্ছে সমস্ত অ্যাকিউট কন্ডিশন। সো দিস ইজ ওয়ান অফ দ্য ইম্পর্টেন্ট কজেস অফ লিউকেমিয়াড রিয়াকশন, শিফট টু লেফট, টক্সিক গ্র্যানুল, cytoplasmic vacuoles and Dohle bodies. All the features can be found in leukemiad reaction that should be in your level differentiated from chronic myeloid leukemia. শুধু আন্ডার মাইক্রোস্কোপেই নয়, তোমাদেরকে এটা থিওরি কোশ্চেনও আসে এবং খুব ইম্পর্টেন্ট থিওরি কোশ্চেন তোমাদের জন্য। differentiating features of leukemioid reaction to with leukemioid reaction with chronic myeloid leukemia. Leukemioid reaction with chronic myeloid leukemia. বাকি সব ফিচার তোমরা জানো, বাট স্টিল কয়েকটা ফিচার তোমাদেরকে জানতে হবে। বলো বেসোফিল লেভেল কি হবে? এটা তো জানো, বলো। ডেফিনিটলি লেস দ্যান 5% বাট মোর দ্যান 5% CML। আর একটা জানো BCR ABL ফিউশন জিন কি হবে লিউকেমিয়াড রিঅ্যাকশনে? পাবো না ডেফিনিটলি। CML chronic myeloid leukemia, Philadelphia chromosome will be positive. বুঝলে? ব্লাস্ট, এক্স্যাক্টলি ব্লাস্ট লিউকেমিয়াড রিঅ্যাকশনে পাবো, হারগিজ পাবো না। সিএমএল এ অবশ্যই পাবো, যে কোনো স্টেজেই পাবো। ফোর্থ, ন্যাপ স্কোর or lab score, leukemia reaction এ increase, CML এ কিছুই পাচ্ছে না, আনচেঞ্জ থাকছে। and clinically splenomegaly due to leukemia reaction splenomegaly হতে পারে কি? আন্ডারলাইং কন্ডিশন হলে আলাদা কথা, বাট ডিউ টু হতে পারে কি? নো। সিএমএল প্রলিফারেশন হচ্ছে এক্সট্রা হেমাটোপয়েটিক সেল লিম্ফয়েড সেলের, সো স্প্লিনোমেগালি ইয়েস। মনে থাকবে পয়েন্টগুলো, এটুকুই যদি লিখে আসো যথেষ্ট। and of course the conditions of leukemia reaction কি কি সেগুলো কাজ হচ্ছে না। মাইলয়েড টাইপ এন্ড লিম্ফয়েড টাইপ। মাইলয়েড টাইপ মানে মাইলয়েড প্রোজেনিটার সেলস গুলো কিছু দেখতে পাওয়া যাচ্ছে, লাইক সিভিয়ার ব্যাকটেরিয়াল ইনফেকশন, সিভিয়ার হিমোলাইসিস, হ্যামারেজ, মেটাস্টাসিস অফ বোন ম্যারো এক্সেট্রা। লিম্ফয়েডের ক্ষেত্রে ইনফেকশিয়াস মোনোনিউক্লিওসিস বলেছিলাম, কি বললাম? অ্যাক্টিভেটেড লিম্ফোসাইটকে ডিফারেন্সিয়েট করতে হবে এএলএল এর সাথে। দ্যাট কন্ডিশন infectious mononucleosis or whooping cough, these are conditions of lymphoid leukemioid conditions. দুটো লোক আছে, বা এই লোকটা দুটো এস ওইখানে একটা দেখতে পাচ্ছ, সি সি এস এস সি, these are band forms. এইবার এটাকে কনসেপ্ট করো, এখানে লোক আছে, নেই, গ্র্যানুল আছে, আছে, পার্টি আরো these are beta myelocytes. আর কি আছে? প্রিকাশন সেল সলিউশন, beta myelocyte আছে, band form আছে, reactive pharmaceutical আছে, সব আছে। So shift to left. Yes. Row inside of last. দুটো স্লাইড ছিল না, অফকোর্স তাহলে পরে দিলাম এই দুটো স্লাইড আর একটা স্লাইড আছে আর অ্যাকচুয়ালি আর দুটো অ্যাকচুয়ালি স্লাইড পরে দিলাম কি কি ছিল না, সিএমএল ছিল না আর লিকুইড রিঅ্যাকশন ডিফারেন্সিয়েট কি করে করব এটা এর বাইরে সাইড ছিল, বাট এই সাইডের সেলুলার আউটলাইন অলমোস্ট নরমাল বাট গ্র্যানুলার ছিল এবং এখানে অ্যাপ্রিশিয়েট করতে পারছি নিউক্লিও নিউক্লিও লাইন বুঝতে পারছো? নিউক্লিও লাইন আছে ঠিক আছে। Myelocyte, promyelocyte. nucleus का चश्मा मतलब पाई होता है big shape force nucleus ठीक and issue inverse so basically malignant cell পড়েছিলেন malignant cell features of anastomosis মানে features of anastomosis কি পড়েছিলেন ছটা পার্ট পড়তে nuclear features INC irregular nuclear order its loss of regularity cohesion presence of high NC ratio more than nucleoli presence of nucleoli cellular হচ্ছে abundant cytoplasm আছে সেলের নিউক্লিয়ার অর্ডারটা কি আছে ইরেগুলার ইনটেন্টেড এটা কি ভালো একটা নিউক্লিয়ার সুন্দর নিউক্লিয়ার একদম দারুণ নিউক্লিয়ার ওটা পিছন থেকে নিউক্লিয়ার এবং এই যে সাইটোপ্লাজমটা এই সাইটোপ্লাজমের মধ্যে এখানে একটা রড শেপ স্ট্রাকচার আছে these are blast specifically these are myeloid blast এই যে স্ট্রাকচার গুলো আমি অবশ্যই পড়েছি আর এগুলোকে বলা হয় or if the blast count is more than 20% in facial sphere it is of course is myeloid abundant cytoplasm as rich cytoplasm then তাহলে কি কি আছে চিনলে লিকুইড রিঅ্যাকশন চিনলে অনেক ডোজ হয়ে গেছে লিকুইড রিঅ্যাকশন চিনলে সিএমএল চিনলে লাস্ট চিনলে ঠিক লাস্ট আর একটা জিনিস তোমাদের অ্যাকচুয়ালি যেটা ক্লাস নিয়েছি এটা জাস্ট একবার একটু দেখে নাও দেখে নাও মানে কারণ এটা তোমাদের তোমরা অলরেডি পরীক্ষা দিয়ে দিয়েছো তোমরা পরীক্ষা দিয়ে দিয়েছো